Welcome. My name's Ian Campbell from Palliative Care Australia in Canberra on the lands of the Ngunnawal and Ngambri peoples. Welcome to another round of Thursdays at 3, our regular series of conversations with people living and working at the end of life. Today's guest joins us from regional Victoria. Vitor Rocha is a palliative care lead with Murray Primary Health Network based in Bendigo. Vitor is a gay, Brazilian-born, overseas-trained GP, researcher and palliative care public health advocate. Among other things, his work supports priority populations with their end-of-life journeys, and most recently included work with LGBTQI Health Australia and the development of their new palliative care eLearning modules. Hello, Vitor. Looking forward to our conversation this afternoon.
Hello, Ian. Thank you very much for having me today.
Vitor, fill in the gaps around your bio. Tell us a bit about you. I introduced you as a gay, Brazilian-born, overseas-trained GP, researcher and palliative care public health advocate. Fill in the gaps for us. Tell us a bit about you.
Yeah, it's a mouthful, isn't it? But just before we progress, Ian, I would like to also acknowledge the traditional owners of the lands that I'm meeting here today, the Dja peoples, the First Nation community and country that has embraced me in Victoria. So I'm very grateful to be sitting in this country today. And also acknowledge the LGBTQI elders that have strived for the rights that our community hold at the moment. So we are very, very grateful for all the advocacy that they have established.
Thank you, Vitor. Important to acknowledge the past. Yeah, thank you.
Yeah, absolutely. And we know that any historical implications has definitely a positive or negative impact into future generations. So it's always good to reconnect with those as well.
Indeed.
So just going back a little bit about your first question. Yeah, you presented a little bit of my mix between having a clinical background as an internationally trained GP back in my home country in Brazil, but also a little bit of the work that we have been developed in the palliative care, in the primary healthcare sector as part of my role at Murray PHN. But I would say that what I would like to share more is about the human aspect of my involvement with palliative care.
Mm-hmm.
I'm a person like anyone else. We have experienced some challenging times in our lives. And I personally have experienced the end-of-life journey that was quite, I would say, challenging for my family, from one of my grandmothers who died from cancer. And I was also able to observe the long-standing grief that in somehow was an intergenerational grief that was also absorbed by my generation and the future ones. As you've mentioned before, I'm also originally from Brazil, and we know how challenging Brazil was during the COVID pandemic. So yes. I had also the experience that unfortunately facing grief and loss by distance, by losing some of my beloved family members, but also observing how my community back home had struggled with those very challenging times that Brazil faced during that period. So I would say that my personal experience, along with my professional experience, I would say amalgamate my advocacy engagement to continue working in palliative care.
Vitor, so often in palliative care, it's a personal experience that draws people to this work. Do you mind telling us a bit more about the experience of you, your family, and your grandmother?
Yes, so my grandmother comes from very, very humble upbringing. She was partially literate. She comes from the countryside of Brazil, working for generations in farms into harvesting. So access to education, access to healthcare services was something that I was completely beyond of her understanding. So anything in regards to health promotion, cancer screening, and so forth, was something that she didn't have the health education in regards to that. So unfortunately, she succumbed into colon cancer, but it was only diagnosed in the later stages by her family physician. And due to the same extent, Latin communities and many other communities face quite substantial, I would say, sometimes even resistance to discuss end-of-life care and what that entails and what that is involved and how people could be better involved into that. And it wasn't different in my family. My parents, they tried to provide the better end-of-life care that they could to my grandmother during that stage. However, they didn't have the technical skills to do so, or that I would say the substantial support from services during that time. And we are talking about something that happened in 25 years ago. So palliative care worldwide, even in Brazil, was still into their infant stages.
You mentioned the role that intergenerational trauma played for your family and your grief and bereavement journey. Can you help us understand that a little bit better?
Yes, absolutely. So grief and bereavement is something that it's always challenging, and as human beings, as I've mentioned before, we will face that, or we had faced that in the past. It's all about a process of acknowledging that someone has died, and also embracing the legacy that the person have left to your family or to self. And the impact of that, it can be quite substantial, especially when the death is traumatic, like the case of my grandmother. They experienced quite substantial pain and suffering at the end of life. Yeah, but also how to access services, for example. That's why I think I'll go back into that health promotion and health education component. If communities are fully aware of the supporting services available to them, and they feel supported by the system, but also the networks in community that they have, that experience could be different, could be more positive, which unfortunately it wasn't the experience from my family during that time.
So it's that negative experience, that pain your family saw your grandmother go through, that perhaps made your family reluctant to engage with palliative care, engage with end-of-life planning and death and dying themes.
Yeah, not only specifically only with death and dying, and I think that what triggered me into pursuing working with public health for system improvement to promote better outcomes for communities in general, but also pursuing a clinical career. I think that have embraced on me the values of humanity and holisticism, and how we can better work together as colleagues in a collaborative way that we look at the patient into their complexity, and how we can establish those networks within our own skill sets to promote the better outcomes, the better health outcomes to that specific individual. But also, I would say within the communities that they are included as well. So it's not an isolated or individual type of intervention.
Vitor, I'm keen to talk to you about your work with priority populations, but if you can bear with me for one more question around your Brazilian background, and I guess learning from that and sharing some of the wisdom that comes from that. You mentioned, and I hope I get this right, that perhaps Brazilian culture is reluctant to engage with death and dying, and there's some stigma, some taboos around that within Brazilian culture, equally within Australian Anglo culture as well. But what is it about Brazilian culture that makes that a hurdle for people, that makes death and dying a taboo within Brazilian culture?
I would say that the Brazilian community specifically, and that's only from my personal experience, it's changed a lot. It's beautiful to see how the newer generations are advocating for change and pursuing better outcomes in so many different scenarios. But the Latin culture is still quite, I would say, quite conservative in some point of views, and it's not different from that. We know that across different communities in multi-faith group, people pursue death, dying, and grieving in different perspectives. And I think it's only about the best way that we could, I would say, mix your cultural background with your individual experience. And I would say that by having access to education or discussing about that openly, and that's why we are here today, right?
Took the words out of my mouth. Yep.
Yeah, exactly. So that's why we are here today to, I would say, I think differentiate a little bit of the meaning of those experiences that we had in a more lighter ways, and also allow ourselves to feel, to be more open about our considerations and our perspectives, and how we behave in certain ways, or what we pursue things in certain ways as well. Allow ourselves to be vulnerable, I would say.
Yes. Right. Let's talk a bit more about your day job, Vitor.
Yeah.
You help priority populations with their end-of-life journeys, and most recently you've been working with LGBTQI Health Australia and the development of their new palliative care eLearning modules. When we talk about priority populations and you working with them, who are we talking about here, Vitor?
We are talking about the beautiful intersectionalities that we have here in Australia. We have intersectionalities going beyond sexuality and gender, LGBTQI communities that I identify with. But we are also working alongside culturally and linguistic diverse communities, which that's what we see in the beautiful, I would say, Australian society nowadays, how different groups, cultures, and religions and faith and beliefs are able to live very beautifully together in the same society. But also other groups that we could also bring together to those conversations. Regional and rural communities, for example, that are also facing a different of challenges and opportunities as well. But people
Yes.
also living with disabilities. And I think Palliative Care Australia was reinforced quite substantially the importance of people living with disability in the latest budget submission as well to the Department of Health and Aged Care, for example. So it's bringing all those groups together and systems together and collaborative approaches to ensure that every Australian, regardless of their background or where they identify with, have equal rights and equal access to care in palliative care specifically.
Vitor, each one of those communities that you work with could be an episode of Thursdays at 3, and maybe we'll do that into the future, but we'll certainly do our best every day here at PCA, and indeed you with Murray PHN as well, to try and represent those different communities and their palliative care needs. But let's spend a bit of time, I guess, talking about the community that you connect with, that you identify as a part of, and the work you've just done with LGBTQI plus Australia. And their new palliative care e-learning modules. Give us a sense, I guess, of the issues around palliative care that the LGBTQI plus community have, or the sector needs to be aware of.
The LGBTQI communities, unfortunately, historically have faced quite challenging experiences with end of life and grief due to the HIV and AIDS pandemics. And this has impacted, and I will go back into the intergenerational trauma and experiences that we have faced, and even how we connect nowadays with healthcare services, for example. And those experiences, Ian, had impacted us in different levels. So, for example, how we establish a good rapport with our healthcare service providers. And I'm not only talking about specialist palliative care, but also our general practitioners or registered nurses, the allied health, other specialist services, and so forth. But also, how safe do we feel to express our sexual and then gender identity if we feel like we could be fully ourselves with now any concern or fear that our needs wouldn't be unmet. And I think that's some of the challenges that our community have faced. And unfortunately, discrimination as well. Discrimination when we are walking on the streets, if we feel safe to truly be who we are, and how we can express that, knowing that there wouldn't be any sort of negative implications from that.
So bringing that discrimination that many in your community have felt out there on the street, perhaps bringing those concerns, those fears, those feelings, that trauma into those healthcare settings.
Yes, and I think what LGBTQI communities have faced quite substantially, and this comes definitely from a historical component, is the small microaggressions that we face every day. Small comments, small rolled eyes that people may come upon us by the way you are dressed, or by the way you are portraying yourself, by the way you identified within your sexuality and gender. And those microaggressions, even though we are a very resilient community, and I'm very proud of that, in a long term can definitely impact in your quality of life and the health outcomes that you have, but also the relationship building and trust that you have with services. And I'm not talking only with healthcare, which is my experience, but across other dynamics as well.
Vitor, could you give us some examples? Perhaps they're examples from your own life, or stories you've heard from others in the community. What are some examples, some stories around those sort of microaggressions that you point to and the impact it has?
Yeah, I do quite substantial work with the trans and gender diverse community, Bendigo and beyond here. And I'm actually one of the community of management groups. And what trans and gender diverse communities specifically are facing in regional Australia are microaggressions around their gender identity. So this could go through being approached on the streets about the way they identify with and being questioned about that. And some very, very invasive questions that I don't think that's the space for us to discuss here. But also, unfortunately, when they're accessing health services as well, simple as, for example, the gender that they identify with is not the gender that is displaying their medical records, or the pronouns that they are addressed is not aligned on how they identify with.
Mm-hmm.
And there are a lot of other experiences as well that those groups are currently facing.
Vitor, the training that you've just helped shape with LGBTQI plus Health Australia seeks to address this. What are some of the things that those working in the palliative care sector, the doctors, the nurses, the volunteers, the allied health professionals, what are some of the things that those people can take from this training?
Yeah, the training that LGBTQI Health Australia has developed is an inclusive eLearning platform. So we have actually 4 modules that go through different set of teams. So it goes through very foundational introductions to LGBTQI concepts and the way that we interact with each other, but also the barriers that we face when accessing healthcare services, for example, including the examples that I've mentioned before, but also some of the enablers that healthcare services could implement immediately, but also looking in the medium and the long term in ways that we could ensure that those spaces are very safe for our community, but that also that support the organization to even bring some of those concepts to other diversity and priority populations group as well,
Yes.
as I mentioned before. So I think it's definitely an e-learning platform that is leveraging that opportunity for diversity and inclusion in the organizations.
Does it frustrate you that this sort of training is needed? That we just don't know this as good humans? Does it frustrate you that we need this sort of training?
I think it's society is always evolving, Ian, in so many different concepts. And I think, and that's why I've mentioned before about my experience with the Brazilian society is that we have a newer generation that is voicing their needs and is voicing equality and inclusion. And I think society always involved with those concepts. But I think it's our role as healthcare service providers to follow that voice the community is telling us from the people who have the lived experience and ensure that our practices in our systems are in accordance to that, and be very also open into consider, for example, building our education and awareness through the e-learning education model, as I've mentioned before, but also into looking into our systems and processes, policies and procedures, and see how we could better implement that. What kind of sustainable approaches we could have to ensure that the legacy of that inclusion in diversity is definitely a priority and is within our strategic plan and values as an organization, for example.
What are some of the benefits you've seen, Vitor, from those health professionals, those service providers that do take this on board, that do this thinking, that do this training? What are some of the benefits you've seen, whether that's through your work at Murray PHN or those who are engaging with LGBTQI plus Health Australia? How does this influence people in their work and patients in their life?
Very similar to palliative care experiences, Ian. So for someone that have never had, I would say, the opportunity of discussing more comprehensively about death and dying and everything in between in the palliative care, after I introduce people to those conversations, they feel more empowered. Mm-hmm. Firstly, to consider if their approaches are in accordance to that, if they are very inclusive and diverse, but also, and I think it's human nature by the end of the day, they are very future focused into how we could better promote and bring not only my self-practice, but everyone that I work with into those best practices. Because what connected us as human beings, I think it's about see the better of ourselves. And I think we had greater examples of the very saddening stories and facts that happened last weekend in Sydney, for example. We could see that communities they rely on each other, they are supporting each other, and it's not different. And the work that we are doing at Murray PHN with the Caring Circle project, which is our palliative care initiative, it's been incredible, inside and out. We could see general practitioners and their colleagues, practice nurses, and allied health, working together to see how we could be more inclusive in our practices, not only for palliative care, but also LGBTQI communities. But also internally, we are seeing a lot of colleagues that are now accessing support services for palliative care or being more aware about their wishes and goals at the end of life. And it's the same thing for LGBTQI communities after people have the opportunity of building up their education and awareness and knowledge into our needs.
It's a great point you make there, Vitor, that palliative care and the values of palliative care, and indeed the values of the training and the thinking that we're encouraging people to do, call on our best selves, remind us of our best selves, and put that front and centre. It's a great point that you make. Vitor, I'm keen to talk to you a bit more about your, I guess, life in a regional community and your work with primary health providers.
Yeah.
What role can GPs, nurse practitioners, that primary health interface play in palliative care?
I'm a GP myself, so I would say that what triggered us as providers to pursue a general practitioner training, not only as a medical training, but also registered nurses and allied health who are working for the sector, is the long-standing connection and relationship with our communities. Sometimes we live and work in the same communities. And I think that's the beautiful thing about living and working in regional Australia, is that you would know more comprehensively about the needs that your community faces, but you also would establish some networks, both professionally, but also personally, in ways that you could support those people to achieve their better health outcomes. And that's the role of primary healthcare networks as well across Australia, is to leverage those existing skill sets the general practitioner already have, their long-standing relationship, but also their centered role into the healthcare system, right? So they are the ones that it's gonna be following someone through their whole life. They are someone who will be able to capture any changes in people prognosis, for example, from a condition or from a medication management. But they will be also the person that will be linking that individual with the other levels of care. And the same applies for palliative care, right? So they are that individual that is connecting through the network of the healthcare service by itself.
What supports do primary health need to be able to play that role and step into that palliative care space?
General practitioners already have, in general practices in general, and all the providers involved, they have incredible skill sets around how to better support patients within sometimes the time constraints that they face due to challenges in workforce. And I'm targeting here specifically regional and remote communities. They would need potentially more time even to access those trainings, and having some further time to allow themselves to reflect the content that they've been exposed to, but also to create mechanisms to implement that systemically. And general practices staff currently are already doing that amazingly, right? They're already doing that within their existing time constraints. And I think the beauty of connecting with GPs through our PHN work is that to see that engagement and their pursuit of how can I better support my patients. And that's the value that we're coming across with those providers. Even with a very, very challenging system, they are trying their best within those mechanisms. So sustainability within the work that they do, and I think also leveraging their amazing skill sets in ways that is in accordance to their capacity too.
I'll include a bunch of links to supports and training and a whole range of information connected to everything we've been talking about within the show notes of the podcast. Vitor, as we've touched on, you're living in Bendigo, a regional community in Victoria. Do you think country people approach death and dying differently? Is there a different mindset that country people face death and dying with?
I don't think so, Ian. I think it's human nature to face death and dying within their frame of reference and bringing together their life experiences and everything in between. I would say that an extremely exciting, I would say, aspect of regional and remote communities, their community networks.
Yes.
I could certainly say nowadays that I feel part of a very, very amazing community who had embraced me, even though I come from overseas, in ways that I feel that I belong. I feel that I'm part of the Bendigo community, and that I have networks that are not family bounded to me, but I know that there are people that I could rely on, specifically the LGBTQI folks that I have established connections here. So I'd say they have become my family of choice. And I think that's the opportunity of healthcare services, and some of the things that we are trying to do as part of our palliative care strategy at PHN is that how can we empower communities to establish informal networks of support and bringing the compassionate communities model here to ensure that they can support each other when they are facing challenging times. And these are things that we used to do in the 40s and the 50s, but unfortunately, society has changed, right? How can we identify that our neighbor is facing through a challenging time, and maybe we could offer to do the grocery, we could offer to potentially walk the dog? What are the smaller things and supporting mechanisms we could ensure that people would have access to? And something that I would say, Ian, is that there are amazing hospices and community palliative care services who are based in regional areas who are already doing that. And we have a beautiful partnership with GV Hospice, which is one of the biggest community palliative care services in the Shepparton region, who are establishing those carers network of support mechanisms to ensure that carers are also part of the healthcare system. And I don't want to extend too much my answer here, but carers, honestly, is one of the biggest stakeholders that we have in the healthcare system, right? And how can we better support them for them to enact their role more effectively, but also to ensure that they are taking care of themselves in that process?
It's a great point you make, Vitor, and I guess I speak as a fellow from Bendigo in regional New South Wales, that country towns, country communities really will lead the way in re-establishing those networks around death and dying and re-establishing those compassionate communities. It's how regional communities work, and they will lead the way for all communities. Vitor, I guess rounding out our conversation and thinking about your work in death and dying and how it influences your day-to-day life. How does working with death and dying influence how you live your life?
I would say it is a challenging experience, and I think I wouldn't disregard that. But I think it is an empowering experience as well, Ian, because I think we could see the grassroots values of humanity in people during challenging times. And I think that's something that is it. And I think that's why I could very strongly say that I feel part of the Australian society, is because that value of support, connection, and humanity is so ingrained into the Australian society, which honestly, by my experience, it's beautifully, I would say, embraced also by our First Nations people, is that we are here to support each other. And we have seen like beautiful experiences of that during the COVID pandemic times, and the way we were establishing connections with our healthcare service providers in communities. So I would say that even though I have my down periods as well, which is part of human nature, isn't it? I rely into those empowering experiences, and also people who I have experienced that have died in the way they wish to, specifically LGBTQI people that I knew that they died, but they were surrounded by their families of choices, which means that people that they consider are important to themselves are people that they would like to have themselves around them. Those are people that have embraced their gender and sexuality identities, that the lifetime partner were there with them. And I think that's what keep me going and keep me pressuring myself, even though 24 hours is not enough sometimes. But I think that's my resilience mechanism comes from.
Vitor, thank you so much for your time, sharing your wisdom and your work. We've learned a lot over the last 30 minutes and been reminded of a lot as well. And I really appreciate spending this time with you. Thank you. Vitor Rocha, Palliative Care Lead at Murray Primary Health Network based in Bendigo. Thanks again for your time, Vitor. And thank you to you for tuning in to Thursdays at 3, whether that's via PCA socials or Spotify, and engaging in matters of life and death. This is the last episode in our first season of 10 podcasts for 2024. Our second season will start in late June, but there's a whole host of good conversations you can listen back to in the meantime. And if you have any ideas for future conversations, please reach out, let me know. You'll find advice, tools and support with matters of life and death at the Palliative Care Australia website, where you can also make a donation to support our work. Take care. See you next time.